Thank you for inviting me. I am in Halifax, so I'm speaking from the unceded territory of the Mi'kmaq here, and I know that you also are on territories out there in Alberta. I'm going to talk about building local community-focused research capacity in East Africa and where we've gotten to with our 12 years of micro-research. Please feel free to use the slides and the talk that we're going to do, but if you do use the slides, please let Bob or I know because some of them we use for teaching. So with respect to my disclosures, Dalhousie University pays my salary. Micro-research has received funding from a number of organizations: Academics Without Borders, Dalhousie University, Dalhousie Medical Research Foundation, the IWK Health Centre, Nova Scotia Health Authority, the Royal College of Physicians and Surgeons of Canada, Rotary International, and IDRC, as well as all the local sites. But I have no financial relationships with any commercial interest to disclose. 3 objectives for my talk. One, you should be able to define micro-research and describe its potential applications in both low and high income countries. Identify the challenges for developing research capacity in low income countries and community-focused research even in high income countries like Canada. And describe the top-down knowledge translation gaps in low income and high income countries and how community-focused research can address these. So micro-research is really about addressing Africa's health problems, one small micro project at a time. And it started in 2008 with Robert Bortolussi from Dalhousie University, Jerome Kabachenga, who is from Embarara University of Science and Technology, was actually the Dean of Medicine at that time, and myself in 2008. In addressing health problems, we want you to think broadly about what health means. We're not talking necessarily about acute care health problems. We're looking at health in the big focus: the socioeconomic, cultural, and environmental conditions that contribute to health, social and community networks, individual lifestyle factors, and then all the individual ages. As many of you will know, the Millennium Development Goals, we really did very well when we progressed from 1990 for maternal and child mortality. We decreased it by 50% worldwide, but progress has been uneven, as I'm going to show you in the next slide. And low-income countries have many, many challenges. They have 25% of the global disease burden, less than 1% of the healthcare professionals, and their capacity for local research in low-income countries has only about 2% of the global research funds, even though they've got the most problems. This is the under 5 mortality by Millennium Development Goal region from 1980 to 2006 per 1,000 live births. And you can see in sub-Saharan Africa, while there's been some distinctive improvement over time from 1980 to 2006, still a long way to go. And if you look at the high income countries here, you can see how far we've come and but where the other countries need to get to. It's not about equality as a problem, it's about equity. These problems need more opportunities to do more and different things. It's not about getting the same thing that we have. Now let's talk a little bit about the research gap. When you look at what the Millennium Development Goal donors did, and Canada was a donor along with many other countries, the focus was on providing diagnostics and treatments for infectious disease. So let's focus on HIV, malaria, TB. Clinical training for healthcare providers. Let's teach them how to do cesarean sections for women so we could decrease maternal mortality, and improve research infrastructure. So this building that you see here is actually at the University of Nairobi, and Canada built this building. It's got a level 3 HIV lab inside it. But in the work that was done by the donors for the Millennium Development Goals, there was a big neglect of local investigator-initiated research support and research training in situ. So low-income country investigators are principal authors on less than 4% of low-income country community and health policy and systems research publications. That means that 96% of those first authors aren't from low-income countries, even though that's what they're talking about. They're from high-income countries. And as one Ugandan physician said very aptly to us, we find patients and collect data for donor country studies. That's our role. We don't learn how to do it. And there's no opportunity, and was no opportunity, to ask their own questions and to find solutions that fit. So One of the other gaps is in low-income countries is knowledge translation, taking the science and the research studies and then turning them into action. In Africa, often new knowledge isn't implemented, sometimes because it just doesn't fit or it's wrong for the setting. So here was a study that was published in 2015 that the antenatal corticosteroid treatment versus standard care for reduction in neonatal mortality due to preterm birth, well, hurrah, in high-income countries makes a difference. In low-income countries, it actually has a higher mortality. Wrong thing to do. It also lacks local champions who can push forward those research studies and how to implement them, and they lack the resources to do them. And the inconvenience truth for more donors and governments is that daily demands on these healthcare workers often takes precedence over change. They are barely hanging on to deal with all that they're dealing with to just keep the system functioning because there are so few of those healthcare workers. There's another problem. There's an alignment and complexity problem. The problems in many of these countries, and we donors have only made it worse, have been stuck in silos. So we'll talk about the TB silo, the HIV silo, the malaria silo, the gastroenteritis silo. And the problem is when you're trying to influence decision makers, it's hard because there are so many different voices out there and so many issues raised, and there's no coherence in it. And often they never hear the voice from the community or the local healthcare provider who could say, this is what our real problem is. And there, as well as that, there's often a lack of common vision. So even when you get those local people together, they haven't really thought through what actually needs to be done because they're so busy just trying to do and get through their everyday tasks. Next point I want to make is really one that's very important to understand. All of us like simple solutions to problems because it's the easy thing. It's apply the recipe and you'll get the solution. And that works okay for some problems. You usually don't need particular expertise. The recipe usually works and there's certainty that it'll turn out the same way. It's like making a cake. If you follow the recipe, the cake will be fine. Complicated problems, that's a bit harder. Formula are usually critical and necessary. When you succeed with one rocket to get it to the moon, it increases your likelihood that the next rocket will get to the moon. You usually need lots of expertise and many specialized fields and coordination, but the rockets are similar in critical ways, and there's a high degree of certainty of what the outcome is going to be. In contrast, I want you to think about raising a child, and this is an example of a complex problem. Formulae are only limitedly applicable. Raising one child doesn't mean you're going to have success with the next. Expertise is helpful, but it's not as sufficient. Relationships are what's key, and every child is unique. And there's uncertainty of outcome remains even as you're moving through this childhood. And many of our problems in Africa are complex problems. It's not a simple solution. For the maternal mortality, don't just teach everybody how to do cesarean section quickly. So what happened in 2008 when we were at Mbarara University of Science and Technology as part of a CETA grant, the part we were working on was, in quotation marks, growing the research capacity of the medical faculty. And what we recognized was there was this huge gap. And what they really needed was community-based, community-driven, and community benefiting research projects with the local university supporting them and the local teaching hospitals and training sites. And they were really, really needed to find solutions for local health problems that fit their culture, fit their context, and fit their resources. It's not helpful to suggest a solution that takes millions of dollars to put in when they don't have that kind of money at all. We need solutions that really fit. So what are the parallels and differences between microfinance and micro-research? Micro-research is built on the microfinance principles. Micro-research are small grants to people with good ideas for community-based health research. It's about the local setting, the local teaching hospital, the local capacity building and local coaching, as well as the international coaches that go through there by Zoom or Skype. The outcome for micro-research is not growing the local economy. It's about improving local health outcomes, changing practices, changing health policies, and publications. It's not about repaying back the loan. So what does the micro research program look like? It's got several components. The first part are the micro research workshops. This is where the local site selects people to come together to learn research principles. Each team chooses their own research question. We from the Come From Aways do not have any say in what question is going to be chosen. It's the local people who choose what question they're going to work on. We teach them how to develop a research outline over the rest of the 2 weeks. And they get their first critical review when they have to present to judges at the end of the workshop. And the judges suggest how their project might be improved and if they have the opportunity to go forward to submit a formal grant. Those grants then come in, they get international peer review. I ask the same kind of people that I ask for CIHR reviews to review these kinds of projects. The applicants, the difference here is what we ask those reviewers to do is to say, how can this project be improved? What needs to be fixed to get it up over the high bar? It isn't that you're rated the top project, the second one, and only the top 4 get funded. No, 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 no. If they do a good job and they address all the concerns, they will get their funding. And the funding is only $1,500 to $2,000 Canadian, a small amount. They also get assigned an international coach along with their local coach. They then have to go ahead and get Research Ethics Board approval. They then do the research with their coaches helping them. They then translate their findings into the community, policy, and practice. And they can apply for another $1,000 to implement knowledge translation, and we help them get their research published. So I want to go back and now look at the under 5 mortality by the Millennium Development Goals by 2015. I showed it to you for 2006 before. Even by 2015, as you can see, we're not where we need to be. They're still at 83 here per 1,000 live births, and where they really want to be is over here. Same with maternal mortality. If you look at sub-Saharan Africa, 1990, the mortality rate was 987. The mortality rate per 100,000 births in 2015 was 546. But if you look at it in our kind of region, we're talking 12, okay? A ways to go yet. So the Sustainable Development Goals came in 2015, and what a lot of people forget is these apply to all of us in Canada too. They apply to every country in the world. It's not just about the developing countries, and this is a big difference between what the Millennium Development Goals. And I see a lot of them really do deal with health. Many, many, many of them affect health. So let's see what's happened with our micro research workshop since we started in 2008. So as of January of this year, we've trained over 1,100 people. 47% of them were females, 54% were doctors or nurses, but that means that 45% were something else. And they were all these something else's that are listed here. Yes, pharmacists, allied health, social workers, psychologists, but we've also trained lawyers, we've trained engineers, we've trained a poultry farmer. Lots of different kinds of people have taken the program. We don't choose who comes to the program, it's the local site that chooses who comes to the program. Now, micro research, to give you more of this, is where are we in East Africa? We have programs in Ethiopia, in Kenya, in Tanzania, in Uganda, in Rwanda, and in Malawi, as well as a program in India, one in Nepal, and one in Guyana. To date, we've had 46 different workshops. Of those, there are 6 to 8 people per team, and usually somewhere between 24 and 30 people at a workshop. We've had 141 proposals submitted for peer review. Of those, 120 have been funded already, and the rest are still under revision. We've got 42 projects that are completed as of December of this year, and 45 publications. And now I want to run through some examples, 12 different examples of micro research projects and outcomes. So here's probably the one that we talk about the most because it is so spectacular. So Isha Grant's team in Uganda wanted to know why babies died in the first week of life in rural communities in Uganda. You need to know before her study, almost all of the studies on death and everything that was reported on neonatal death in Uganda talked about babies dying in hospital in the first month of life. But you need to know that 60% of babies in Uganda are born in the rural village community. They're not born in a hospital. So she went to do this. They used the WHO verbal autopsy reporting program. And in that verbal autopsy report, they beefed up the infant questions, which I then took back to WHO, and it changed. The 2014 WHO autopsy report now has those questions in it. That's a pretty big impact if you think about it. And then they went on to find out why these mothers' babies had died. You need to know that you don't talk about this in the Ugandan culture. A baby that's died in the first couple of weeks of life is as if they have never been born once they've been buried. So it took the local people being able to do this program and garnering the people to trust them enough to talk about it. 72 women came forward to talk about their babies that had died. They did the verbal autopsy forms. They answered all those questions, took them to 3 different pediatricians at Makerere University who independently reviewed them. And of those 72 babies that had died, 42% had died from neonatal sepsis related to umbilical cord sepsis. Florence's team in a different part of Uganda, in southwest Uganda, wanted to know about the traditional practices around pregnancy and birth in the Akoli tribes. And they went out and did interviews with the mothers, the grandmothers, the traditional birth attendants, the fathers, and the elders. And they took the WHO standard practices and they said, this is a good practice and would be in agreement with WHO recommendations. This is, who cares? It's neither a good or a bad practice, it's neutral. And then these ones are difficult practices. And among the bad practices, in the culture, they put herbs onto the umbilical cord. It is with a ritual that this is done. Some of those herbs are contaminated with dirt, cow dung, and other things. These 2 teams came together to present their research projects at a micro-research forum. They went, oh my goodness, these 2 studies go together. And then because of connections that others had with micro-research and the Ministry of Health, they were able to present their data to the Ministry of Health of Uganda. The Ministry of Health said, oh, these are people from our own country presenting this. This has not come from a ways telling us what to do. Oh, this is really good research. It's been published in good quality journals, so it must be good research. What do you think we should do about this? And Isha and Florence both said that you can't change the culture. What's recommended in Uganda at that time and what was recommended by WHO is just let the cord dry and fall off. But that's not what the cultural practice would do. So they said, well, could we put something on the cord that would be protective so that neonatal sepsis would be much less likely to happen and still do the rituals? And Isha went back to Luweero district where she'd done her study. They asked the birth attendants, the mothers and the fathers, and more than 80% said, oh yeah, that would work if you gave us something to put on the cord. So they looked at chlorhexidine gel. Then the Aga Khan Foundation supported the government of Uganda to set up a not-for-profit pharmaceutical company. They make Umbagel, which is chlorhexidine gel for the umbilical cord. It is in every mama pack, and so that it can be applied to the stump when their baby's born. And this is now being exported across East Africa. Each of these projects cost $2,000. That's it. That's all. Huge impact. Here's another one. This is a randomized control trial. The question here was, will district health centers use preloaded cell phones for referral calls for women who are in obstructed labor? And it was a randomized controlled pilot study that was done in Mbarara Regional Referral Hospital in Southwest Uganda. And the answer is, as you can see, oh yes, they would. If you gave them the SIM cards and you gave them the number to call, they would call in and say, this mother is coming, she's in obstructed labor, she should be there in an hour, 2 hours, whatever it is, the time frame for her to get there. Because many of these mothers were arriving at the hospital unannounced, in extremis, no OR prepared, no blood ready, and many died before any of the interventions that needed to be done could be done. He's now in the middle of a second randomized control trial to see what the outcome is in a much larger study. Third outcome. This was a second project. After you've done your first micro-research project, you can do a second project. And this was looking at multi-drug resistant TB in the Oromoria district of Ethiopia. And Gurma Malaysia had done micro-research out of the Ethio-Canada program that University of Alberta supported. His second project was supported by the Adama Hospital Medical College. It was mentored by micro-research. They looked at sputum cultures collected in 6 months for presumptive multi-drug resistant TB, and then looked at how many of the clients were positive for a multi-drug resistant TB. 265 or 60% were positive. Well, what was special here, and this is really important, 33% of the MDR TB cases were in people between the ages of 18 and 39. If you look at the literature on MDR-TB, that's not the age group. They'll always tell you it's the old people that have MDR-TB. Yes, they had similar findings from other studies, except these were not urban people. They were farmers, a little bit different as well. No TB contact, and then the other factors I've put here. What's really important here is they were able to take this information after they had it and retool what kind of who was going to get tested for MDR-TB, because they can't afford to test every sputum that comes in to see if it's drug resistant. Here's another outcome. One of the previous micro-research people who'd finished their project went on to write a non-micro-research grant. We know that there's a high mortality rate in Basheni district in southwest Uganda. Many of the mothers, as I've said, have obstructed labor. That's the whole reason that Hampson's doing his project. UNICEF was offering the opportunity for motorcycle ambulances if you did the grant. So they applied. However, when the person who did this application applied, the person said, you know, I do have some concerns about this structure, this motorcycle ambulance being 3 wheels. It might be better if it was a 4-wheel ATV type, because this is what our roads look like. UNICEF said, oh, no, we've got great data. It's perfect, It'll work just fine. So they did the grant. They got the motorcycle ambulances. As you can see with this one rolled down a hill, and the windshield fell out. These are not useful in the hilly districts where these people were working from. Now you have to ask me, well, where was the research done originally that said to UNICEF this was the best thing since sliced bread? Done in Bangladesh. If you've ever been to Bangladesh, it's flat as a pancake. You're not going to roll off a hill. There are no hills. Okay, so that's the problem here. We donors often say research done here is going to work really well over here without really understanding that the context is different, and we need to grow up and not do this. Outcome number 5, we did a follow-up survey to find out if people who'd done the micro-research workshops were continuing to do research. You need to know that workshop after workshop, we found usually no more than mostly 15 to 20% of people have ever done research before. And most of the research they've done is to collect patients, as I've said, or to do something that is to analyze data for them, but never research design, never as a PI, none of that. So we went back in 2016 and did a study of all those who had done the workshops between 2011 and 2015. We weren't able to find everybody because some of the email addresses had changed, but we did find this many of them. And of those, 214 opened. So, and of those, 46% responded. So what did we learn? Well, did micro-research impact your career? 88% of them said yes, and this blew us away. How many of you are still involved in research? Not necessarily micro-research, but research. 85%. And I will tell you, as a former dean of medicine, if I went back 1 to 5 years after people had graduated with their master's or their PhD from my faculty, I would not have 85% of them saying they were still doing research. This is like amazing. This was tapping in to a huge resource of talent and thirst to learn skills that just wasn't there before. Change number 6, outcome. This is about postgraduate resident research training. This was at Kabarak University in Kenya. Their family medicine residency training program, it's a 4-year residency training program. It requires a thesis because that's what the Kenya National Authority on Postgraduate Training requires, that there's a thesis. But the medical theses from graduates from this program were just gathering dust. They were of no value whatsoever. The concern that was raised was the teachers had little to no research experience. The thesis topics were not practical, and they didn't have any idea about knowledge translation. And it was just kind of a little exercise that wasn't very helpful. So they took the micro-research model and we helped them develop it to incorporate into their thesis development program. It's now been applied to family medicine, nutrition, and other areas at Kabarak are coming online to use the same kind of structure for theses for other PhD programs and resident training programs. So what does this look like? Here's some of the examples of some of the questions that they've been asking. What methods are commonly used to procure illegal abortion? And how are they accessed by the women in Bomet County in Kenya? You need to know that illegal abortion is one of the major causes of maternal mortality. What are doctors' knowledge and attitude with regard to inpatient adults and end-of-life care? This is at Kajabi Hospital. How prepared are families to take care of end-of-life issues for their family members who have advanced cancer? You need to know there's no hospice care. There's almost no palliative care. In fact, palliative care is in its infancy. So many women, for example, with advanced cervical cancer end up back in their village in horrendous pain with their families trying to care for them. And they went out to find out what those family members needed to be able to deliver the care that these people really needed. What are the opinions and understanding about vasectomy among married men in Chagoro, Tharaka County in Kenya? And what are healthcare seeking behaviors of female sex workers in Bomet County? It's a rural area in the South Rift Valley part of Kenya. You need to know that sex working is illegal. You need to know when the sex workers arrive at the hospital, they're often ignored and disrespected, so they don't come forward. And many of them have major health issues around HIV, TB, and a whole bunch of issues around pregnancy and healthcare. All of these questions, as you can see, are relevant. All but one of the family medicine residents in the first cohort have now graduated. One left the program, but it wasn't for his thesis. It was because of clinical issues that he had. All are now practicing in Africa. Most of them are in Kenya, and several of them are actually in teaching hospitals and starting to be leaders of the thesis development for the people coming along behind them. And all of them, every single one of them has continued to do research, and the program is now managed and taught predominantly by the Kabarak faculty. Micro-research only has a very tiny part of helping them keep going. Outcome number 7, micro-research, high output, low cost. We're very, very fiscally responsible. Many low-income countries, the research capacity building programs followed, let's bring somebody over to North America, to the United Kingdom, to Germany, to Sweden, to Belgium, and we'll train you up. And it was about $250,000 a year to do that. And you were teaching them to do things that they would never be able to do when they returned home. So what does this very low micro-research program cost? Well, between 2008 and 2016, we'd had 27 workshops, 700 trained, over 60 projects approved at that time, 21 of them were completed, and we did all of that, 700 trained for under $500,000 Canadian. Cheap as chips to do this. And one of the important things we teach them is that you can do research without a lot of money. And it was very interesting for us. One of the micro-research participants in 2017 said, we can do important research with no or only a little money. Lack of money shouldn't stop us. Another participant said, you don't have to be Superman to do really good research. You just have to make it work. So one of the goals we also have is that they should become self-funding. So micro-research really wants each of the sites where it's held that they should be able to get that $1,500 to $2,000. So even if we disappeared off the face of the map, they'd be able to keep on doing small projects. So what we've done is develop links between micro-research in 2 of the sites now and Rotary clubs locally. This one happens to be in Emberera, but we've also done this in one of the other sites too. Those Rotary clubs are then linked with Rotary clubs here in Atlantic Canada. These Rotary clubs do very small projects. I want you to know, this is their neonatal intensive care unit. It has, in addition to these things to sit on, it also has tables to put the babies. That's it. And the mothers have to care for those babies because there aren't enough nurses to care for them in their incubators. What was the problem for the mothers was, and that's what this building here is so much, the mothers would have to leave the baby to go way, way, way down a hall to be able to go to the bathroom or to have a shower. And instead, what the Rotary Club did was they refurbished this, painted it, and they also built this extension, which has toilets and places to shower so the mothers can nip in and out very quickly and not leave their baby alone, unattended. Outcome number 8, we've started micro-research writing workshops. We know that the writing skills to not just write their grants, which is what we teach in the workshops, but the writing skills to write papers were very limited. So we now have done this. Several of these workshops, we've got 4 of them done. We've trained 54 people in how to do this, and we're training the local coaches on how to be the coach people and to be able to run these workshops on their own eventually. To come to one of these workshops, they need to have had their data analyzed. And what we do in the 2 days of the workshop is they develop the backbone for their paper in bullet form, all the way from what's the problem down to what's the gold nugget at the end, what's the big finding in your paper. And we teach them how to do the logic and how to tell the story. And because Bob and I have extensive experience in both writing papers, Dominique, I've actually published over 450 papers, not 100 and some. And I've been an editor for more than 20 years. So outcome number 9, this was huge. We had totally not expected this at all. How many times do we have programs in the South that move north? Well, when we presented our findings from micro-research in 2016 at the IWK and to the Nova Scotia Health Authority, the first questions we were asked were, why are we not doing this in Nova Scotia? We need these kinds of questions and these kinds of skills out there in our communities. And so that's how Nova Scotia micro-research started, exported from the South. So what have we done in Nova Scotia so far? We've done 9 workshops. I have to tell you, COVID slowed us down last year. We have 111 participants and we have 6 projects underway. I've put an arrow here because this has been fascinating. We've had Halifax Regional Police Constables take the micro-research course as part of a micro-research team. And what's been fascinating for us is often their questions from problems that they see out on their beats have been the ones that the teams have chosen to answer and go after. And I'll show you one on the next slide. So here's some examples of Nova Scotia questions. What are the costs associated with the resources utilized by the chronically homeless, alcohol-addicted men in Halifax Regional Municipality? There have been other studies looked at that. Most of them have only looked at healthcare costs. This team is looking at what it costs for them to have the jail time, what it costs for them for the court time, what it costs for them for the emergency health services time, the paramedics time, the community and social services time, not just healthcare. And more importantly, they're asking, what did these affected men say could improve their quality of life? And I want to pause for a minute and tell you a little bit more about this. This project, this workshop was done in the Brunswick Street Mission, which in Halifax serves addicted and alcoholic men that are out on the streets. It's been doing it for many, many, many years. And when the program, the team that did this, when they presented to the judges on the last day of the workshop, one of the judges said, because they said they wanted to interview 20 of these affected men, to find out what they thought would improve their quality of life. And the judge said, well, you know, you're going to reach saturation by the time you get to 8 to 10 men. And a voice from the back of the room said, these men have no dignity. No one listens to them. This is about giving them respect. It is not about saturation. Think about it. That wouldn't have happened if it had been done by an academic in a university. They would have just gone for saturation. So, other question, this came from one of the police constables. What do young women 12 to 19 years of age who were groomed into prostitution identify as grooming techniques that were effective? This constable was working in an area of Halifax where regularly 12 to 19-year-old girls are getting groomed to go into prostitution. He cannot do anything until they disappear because the pimps are not doing anything wrong, nothing that they can be charged with. And they wanted to know, what are the protective things that keep some of the girls from falling prey to these men and women, and what could be done to protect them? When they went to look up the research that had been done on prostitutes in Canada, almost all of it is on adult women, and almost all of it are quantitative surveys, and almost no one has gone back to find out from the voices of these women what they actually really think is going on. This third one is an example from one of our Mi'kmaq communities. Why do First Nation members of Pakakak community consume so much pop and energy drinks? This one was stimulated by two of the people from that community who were on the micro research team out near Antigonish. And what one of those women said is the Pepsi Cola driver told her that he delivers more pop to their reserve than to any other place in eastern Nova Scotia. And she wanted to know why, because they have huge percentage of type 2 diabetes, obesity, and dental caries. So they're trying to find out why this is actually happening. And they already have a knowledge translation plan. They're planning on bringing a wheelbarrow full of sugar to the band council meeting to show how much sugar each person is taking in every year on that reserve. Outcome number 10, micro-research in Nova Scotia and Mi'kmaq communities and beyond, a work in progress. So we've had 4 Mi'kmaq taken the micro-research Nova Scotia in 3 different workshops. They raised the question, each one of them did in all 3 workshops, why are we not doing this for our Mi'kmaq on reserve? So Audrey Steenbeek, who's a professor of nursing at Dal, and she has worked with Indigenous communities both in Nova Scotia and Atlantic Canada, as well as up in Nunavut. And she's also very active in micro-research as a reviewer, a coacher, and a teacher, both in international micro-research in Africa as well as in Nova Scotia. So she's working with Christy Barnaby, a graduate student who was a Mi'kmaq graduate of micro-research, who's a health admin graduate student, to develop and indigenize the Nova Scotia regular curriculum. We've had requests for this Indigenous program to be taken to Northern Saskatchewan, to Nunavut, and just last week from Powell River, the family physicians that are there and the community and the Indigenous community there had one of their people call me up to find out if there was a way we could do it there as well. And we might be able to do it now that we're virtual. We've also had police chiefs from a number of cities across Canada, because the micro-research programs that have involved police questions have been incredibly helpful for the community, and they want those same skill sets in police departments in other cities across Canada. Outcome number 11, well, what's happened with COVID and micro-research? Well, I'll tell you, it's been really hard for us to do our usual workshops, either internationally or in Nova Scotia, because they were in-person workshops. So we've now changed them to virtual. And we've done some of these virtually internationally, and the writing workshops, the train the trainer workshops, as well as the usual regular workshop. We've got another one that's starting next week in Malawi, virtually. 3 of the micro-research projects that came in are actually COVID related. And one of them, I'm just telling you here, this is the impact of COVID on adolescents in Western Uganda. Big migration back to the villages from the kids that were in the schools across the country. It's led to marked increase in the risky behaviors among these adolescents, with violence in the home, underage sex, sex for money, and rape. And this is a hugely negative impact of the COVID lockdown in that country. So one of the other things that we've been asked, and I'm just going to come to outcome number 12, is the Sustainable Development Goals. Is there any way the micro-research principles and strategies could be applied to do more than just health problems in sub-Saharan Africa? Could it be about housing? Could it be about clean water? Could it be about sanitation and roads and jobs and environmental issues? So outcome number 12, moving beyond micro-research in health, Academics Without Borders, one of our partners, has taken the micro-research model and worked with partners in Africa, including, this is Williams, who is a biomedical engineer at Mbarara University, and he has a PhD, which most of the faculty in engineering at most of the engineering schools in Africa, well, in sub-Saharan Africa, they may have a master's degree at the most. And he took micro-research so he could learn and help to train other people in his department on micro-research principles. Academics Without Borders has now adapted micro-research to strengthening engineering education and research program called SEER. The first site is going to be at Mbarara University because it's the strongest micro-research site, has the oldest and most people trained. And I think their first workshop is going to start, I think, in June. And this is a huge new beginning to try to help solve some of the road problems, transport problems, and many other things where engineering can make a big difference. Next, I just want to say, in summary, what micro-research really is. Micro-research is about social accountability. It's about equity in action. It's about communities being supported, whether they're in Africa or India or in Guyana or in Nepal or here in Nova Scotia, in recognizing community problems and then with help, finding solutions that fit the context, the culture, and the resources. And here's a bunch of quotes for you. The Superman one I told you about before. Here's another one. Micro-research was eye-opening, and I am positive that it will change my life. Micro-research ignited the dead researcher in me, and I'm now sure amongst all of us, this is the first time I could think of problems outside my discipline. It feels so great. These will be lifelong skills that will aid in our careers. And one of the best quotes we ever had came in 2011, and one of the people at that workshop said, the difference with micro-research is you teach us how to fish. But not only do you teach us how to fish, you put fish in the lake and you show us where that lake is. So for sure, we're going to be able to catch fish. So we've got many, many, many partners in micro-research, particularly Academics Without Borders, Dalhousie Medical Research Foundation, the IWK, Nova Scotia Health Authority, private donors that have given us small amounts of money, but they've gone a long way to help us, and the participants and site leaders who give up their time as volunteers. They're not paid to do this. The only monies that we use are for the project proposals, and Academics Without Borders pays for 1 or 2 people to go to pay for the training. That's it. There isn't a whole lot of money in this. That's why the workshops are so inexpensive. So all of the people and sponsors, you can see the list here. I want to point out the University of Alberta. We've had certainly people from the University of Alberta who've come with us. Dominique has been one of the people in Uganda, and also helped with Ethio Canada and the piece of micro-research that we did with them. So one of the questions we get usually asked after we've done a presentation on micro-research is how to help. Well, if you go to the micro-research website, www.microresearch.ca, not .com will get you Microsoft software stuff, .ca, and see where it says ways to help. This is not about, yeah, you can donate money if you want, but if you pick on that and you scroll down, it tells you how to sign up to be a teacher or a reviewer or a coach. And all of those things, we always need more. Thank you for listening.